Good evening. It's now 6 o'clock and this event will now start.
Thank you. Welcome, colleagues. My name is Claude Ndlovu. I am the head of professional affairs at SAMA. And thank you for joining us at this webinar that is hosted by both SAMA and the SA Medical Research Council. I have my colleague here, Dr. Mongezi Mdluli, who also is my co-host, and he will greet you as well.
Good evening, my co-host, Dr. Ndlovu, which is my fellow co-chair. Good evening, the presenters, Professor Glenda Gray, Dr. Mvuyisi Mzukwa, Professor Linda Gale Becker, Dr. Shirley Coley, Professor Ames Dai, the facilitator of the discussion, Dr. Vismus Nhlwapo, and lastly, we will have Professor Liza Zulke as well as Dr. Ngwenya, who will do our closing. It is my absolute pleasure to be part of this webinar and for all my students to be afforded the opportunity to co-chair this important session. As my co-chair has already indicated, this webinar is hosted jointly by the South African Medical Research Council as well as the South African Medical Association. It is now my absolute pleasure to introduce the program to you. We'll firstly start with our CEOs, both from SAMA as well as the South African Medical Research Council, and I'll hand over to my co-chair to introduce both. Thank you.
Thank you, Mongezi. So we'll do the first welcomes by both the chairperson of SAMA, Dr. Mvuyisi Mzukwa, as well as Professor Glenda Gray, who's also very much well known to all of us as the President and CEO of the South African Medical Research Council. I'll start with you, Dr. Mzukwa.
Thank you very much, Dr. Claude and Mongezi, for that introduction. Colleagues, I would like to just quickly do this welcoming intro, and I would hand over to Professor Glenda Gray. As it has been said already, SAMA and the South African Medical Research Council welcomes you to this webinar. We'll be sharing lessons learned 3 years into COVID-19 pandemic. Colleagues, the pandemic has been challenging to the medical profession. It has helped bring focus into the health sector. I can say because of the challenges here and globally, the pandemic has placed tremendous pressure on healthcare professionals. And sadly, as you know, some lost their lives in the provision of care to their patients. From this webinar, we are going to engage in understanding this impact. What lessons have we learned during the pandemic? What is the ideal vaccine program to ensure immunity? How do we protect our healthcare professionals who are still on the cold face of the pandemic? We are delivering this webinar at the back of the summer conference, which brought together speakers from various fields around the theme, Beyond the Pandemic. The South African Medical Research Council CEO, President, Professor Glenda Gray, delivered a keynote address at this conference. And this brought to light the research that was conducted on the coronavirus. Colleagues, we're not beyond the pandemic. We're still grappling with the new normal. As key stakeholders in this field, once again required to provide direction on what this new normal will look like. How prepared are we for the new variants? How do we prepare the citizens for the next wave or the next outbreak? It is important to reflect and learn from the past and to have conversations about how best to manage future health emergencies. I'm now going to hand over to Professor Glenda Gray to say a few words. I thank you.
Thank you very much, Summer Chairperson, esteemed panelists, and the MC, all protocol observed. I'm very happy to be able to say some opening remarks here, and to also thank the panelists for, first of all, for agreeing to come onto the panel, and also for their great commitment that they have put in towards understanding COVID and COVID vaccinations. So as we sit here on World AIDS Day, I need to say that already 13 billion doses of COVID vaccines have been given at a global level, unprecedented amount, of which around 70% of the population have received at least one dose of the vaccine, but only a quarter of people in low middle income country settings actually have got the vaccine, which means that there's huge disparity between rich and poor countries. At this stage, 2 million doses of COVID vaccines are given every day at a global level. If we look in South Africa, we've managed to vaccinate about 38 million South Africans, and we vaccinate about last night, or sorry, on Wednesday, we had vaccinated around 7,248 people at a country level, which is far down from what we were doing when we were rolling it out at our peak time. We have just under 50% of our population, of our adult population, vaccinated, and around 67% of people over 60 years of age. And so we do have to work much harder at trying to make sure that people get more than their primary vaccination schedule. In the future, hopefully, we'll have new vaccine platforms that will hopefully increase the breadth of protection and give us much more neutralizing antibodies, the antibodies we need to try and prevent onward transmission. Our vaccines at the moment are very effective against protecting against death and hospitalization, but have less impact on transmission. Hopefully, new platforms will come and will emerge that will impact on interrupting transmission. We need more varied immunogens, and hopefully we can find a vaccine strategy that will give us a yearly boost as we go forward. COVID is going to be with us for a long time, and we're going to have to learn to live with this, and we're going to have to get ready to have annual boosts while we try and control SARS-CoV-2 at a global level. And so I'm very delighted to hand over to the rest of the panel and welcome you again for coming to attend this webinar on World AIDS Day. So thank you very much.
Thank you, Prof.
Thank you very much, both to Dr. Mzukwa and Professor Gray, and Dr. Mzukwa for reminding us about the lives lost, our families, our relatives, the people that we know, the understanding of the impact that the COVID had in our lives, and also reminding us that the importance of vaccination, of which also Prof. Gray has touched on, and that the pandemic is still here, so that we do not forget. And secondly, how we prepare ourselves for any new variant, as well as a new pandemic. And Prof. Gray, talking about the World AIDS Day, the importance of vaccination and the amount of vaccination that has been administered, and also the issue around the inequity in terms of vaccination, and also pushing the drive in South Africa to have our population vaccinated. Reminding us again that vaccination is quite important to stop the transmission of the virus. Now, I'll hand over back to my co-chair to introduce our next speaker. Thanks.
Thank you, Dr. Mongezi. So we are now getting to the meat of this webinar, and our next speaker is Professor Linda Gail Beckham, who is the director of the Desmond Tutu HIV Center at the Institute of Infectious Disease and Molecular Medicine and Department of Medicine at UCT. She is the CEO of Desmond Tutu Health Foundation and is an NRFA-rated physician scientist and specialist in HIV and related infectious diseases. Prof. Linda Gail Becker's He's a past president of the International AIDS Society, involved in a number of COVID vaccine trials, and co-lead the Sisonke phase 3B study, which seen the vaccination of over 500,000 healthcare professionals in South Africa. Prof, thank you for your time and welcome. Please take it away.
Thank you very much to the co-chairs and to the President and CEO and all of you for joining us today on World AIDS Day, and happy World AIDS Day to all of you. And it's my great pleasure to be part of this webinar today. My task is to really look at the pandemic as a physician scientist, but I also unapologetically look at it as a vaccinologist. And so let me take you through the talk that I've prepared today. Well, of course, we came to know about a new virus and a new pandemic, which was called COVID-19, just in December of 2019. Doesn't feel that long ago. It's Central Point Wuhan in China, and it was declared by the WHO as a pandemic in March of 2020. The cumulative proportion of population infected at least once is shown in this map, and this was published in 2022 with more than 540 million cases and over 6 million deaths to date. This graph shows the daily and cumulative deaths that have occurred around the world, and you'll see Sub-Saharan Africa there in purple. How has it looked for us here on this continent? And certainly we've seen at least 4 waves. If you consider the 5th wave as part of the Omicron variant wave, and over 12 million cumulative cases, 250,000 deaths. It's important, though, to interrogate these deaths more closely. So the COVID-19 reported deaths as a rate per 100,000 persons is shown in this graph. But when we look at the actual excess mortality as come to be known around the world, compared to as a ratio, compared to what has been reported, then you see that there are certain parts in the world where deaths have really been very underestimated, and certainly Sub-Saharan Africa, Southeast Asia, Central Asia being those areas in particular. So there's no doubt that the COVID-19 pandemic has cost us directly in lives. And again, recognizing that here on this continent, there's been quite a marked under-reporting of deaths. But it's also cost us indirectly. And here in this graph, just showing you that somewhere between 5 and 30 million have been pushed into extreme poverty as a result of the epidemic. And when we look at the impact on poverty and hunger, an additional 140 million children in developing households are projected to be living below the poverty line. A modeling study has been looked to see what the effect of COVID will be on extreme poverty. And here you see that 73.9 million there's been an increase to 73.9 million in 2020. You'll see how the impact will even carry into 2050. And 7 more countries will not reach SDG, Sustainable Development Goal 1, by 2030 as a result of the COVID pandemic. So we've been set back in many ways because of the COVID-19 pandemic, and the impact on poverty is most felt in South Asia and Sub-Saharan Africa. It's had an impact on other diseases, and the other important epidemic we think of here today, especially on World AIDS Day, is that of HIV. And here you can see around the world how HIV testing fell, cumulatively more than 20% reduction, but some countries feeling this more than others. Also, COVID-19 had an impact on HIV care, and this is a study looking at the South African lockdown and attendance at health facilities, and you see 50% reduction in HIV testing, 46% reduction in ART initiations. Pleased to say no marked change in ART collections, and this is probably because we are a country that has already moved to differentiated service delivery due to the fact that we have almost 6 million people requiring antiretrovirals. And so we had already innovated around things like multi-month dispensing and distribution of antiretrovirals in innovative ways. And I think there's a lesson in that already for us for future pandemics. COVID-19 had an impact on other vaccinations, and this is important because childhood vaccinations are a mainstay for public health, and you can see that 25 million children missed one or more DPT-3 doses in 2021, and it's thought that this really is going to, it seems even that this drop in childhood immunization has continued, so there's a hangover. And we're continuing to see rates declining. So it's almost as if people have kind of got over vaccination and have thrown all kinds of vaccinations together, and even their children are bearing the brunt of this now. So we are, at risk for all kinds of childhood epidemics in the future. What about education for children? Now, we know very well that COVID-19 was really a disease of the elderly. Children not being at risk for severe outcomes as a global public health measure for children, but certainly they paid a deep price when it came to schooling. And you see again, the poorest countries suffering the most because of a global student internet access, and around 131 million school children have missed 3/4 of their in-person learning, again, due to lockdown, school closures, and so on. So we expect really a generation to have lost significantly when it comes to education. And Human Rights Watch, called the alarm on this to say that these closures have really had an impact on other inequalities. We know children receive food at school. The digital literacy was unequal, limited internet access, and of course, girls disproportionately negatively affected, as well as those with special needs. And this again calling, particularly today, where World AIDS Day tagline is about equalize the unequal aspects of our global community. So let me turn quickly to South Africa as a case study here. And you see where South Africa sits in terms of other countries as far as cumulative COVID-19 cases go. South Africa certainly had a great deal of infections and deaths in Africa, although that compared to other parts of the world was relatively less. However, in South Africa, with only the non-pharmaceutical interventions at our disposal, no vaccines as yet, one of the measures we undertook was to flatten the curve. So what this means is where we reduce the risk of people being exposed to contagious cases by reducing person-to-person contact. And it is well known that South Africa had some of the strictest regulations around the efforts to try and reduce transmission from case to case. So this concept we came very well to know of flattening the curve, with lockdown starting all the way in March of 2020 and extending all the way through, as you see in the graph here. We all remember those days where animals found their way back into society and streets were empty, as well as the harrowing time of really trying to maintain these lockdowns in the face of a population had many competing priorities. And certainly, again, this laying bare inequalities. For some, the lockdowns meant not being able to walk the dog or having to queue for groceries. But for others, it was about losing employment, queuing for grants, and having to live on very little. in crowded and, lockdown townships. The impact of COVID and lockdowns also saw a rise to gender-based violence. And this study, recognizing that the pandemic prompted an escalation in gender-based violence. And you see again, just some anecdotes from young people recognizing that because of not only economic pressures, which can definitely lead to gender-based violence, but also just the cabin fever, that, we saw an increase in interpersonal and gender-based violence. The alcohol restrictions may have alleviated that somewhat, but certainly I think another aspect for us to think about this other epidemic in South Africa, that of violence. So this is how the epidemic has played out for us. In terms of the lockdowns, we started with the ancestral wave, then moved into the beta wave, the delta wave, and the Omicron wave. Of course, at the time of the ancestral wave, we did not know that variants of concern would arise. And really, we were just managing on a day-to-day basis. Here you see hospital admissions following those waves and the pressure on beds, on our healthcare workforce. And then, of course, tragically, the COVID-19 related deaths that occurred with that. We know, however, as I have already described, the official numbers very much underestimating the reality. So although we reported over 100,000 deaths, probably somewhat more like threefold more individuals having lost their lives due to COVID. And again, although the majority over 60 years, we certainly did see a significant number of younger people. So in 6 months, this RNA virus, and perhaps we should have recognized and expected this, began to mutate. And these were described as variants of concern. A variant of concern is something that is the mutation results in a change of transmission, dynamic, or leads to vaccine escape. And indeed, this became very apparent. So on the first hand, variants drive waves. So because of the change in the virus, it creates a new surge of infections. And so these waves became well known, ancestral, followed by beta, delta, and then Omicron. But we also have to think about how variants of concern resulted in vaccine impact. The question being, were these variants caused either by the need to be more transmissible or in the need to escape from vaccination? And I'm not sure that the jury is out yet on which of those two possibilities drove the variants. However, here again, you see how the various waves caused cases, hospitalization, and death. And then this phenomenon in the Omicron wave where we saw the uncoupling. So where cases started to not result in quite the same number of hospitalizations or deaths. So a change in the dynamic of the virus and its impact as a cause of epidemics and pandemics. So this really speaks to the transition of the interaction between the pathogen and the global community. So a pandemic is an epidemic which occurs worldwide over a very wide area. It crosses international boundaries and probably is because you have largely an immune naive global community. An epidemic is an increase, often sudden, in the number of cases of a disease above which is normally expected. And then endemic really indicates permanence when a disease is prevalent at a relatively constant baseline. So it seems that we have had a shift from pandemic to endemic. First of all, pandemic with the worldwide ancestral strain and really collectively no immunity in the country. We then saw these novel variants, which, if you liked, caused waves of epidemic infection in various parts of the world. There was a time when we had a lineage in South Africa, the beta wave. We had a different variant in Brazil and a different wave in the US, all happening at the same time. And then the question is whether we're moving now into an endemic post-Omicron stage where there are sublineages, but an expanded immunity. So many more people now immune, and this uncoupling, which I described. So vaccination plus infection and breakthrough infection leading to increased hybrid immunity, and thereby this change, if you like, in the dynamic between the virus and the human host. We, of course, were very concerned here, and today it's important to recognize as we think about HIV and our global HIV, our countrywide HIV community, almost 8 million people living with HIV. And you'll remember we were very concerned about what the implications were for that community. And the Western Cape Public Health team were some of the first to show the risk factors for coronavirus disease. And they were also the first study to demonstrate an increased risk of almost twofold amongst people living with HIV and slightly higher risk amongst people living or dealing with disease of tuberculosis at the same time. When you unpack HIV into the stable, well community and then the not well or virally unsuppressed, then you see that risk of COVID mortality increases. So going up to 3.8-fold. We started to also hear about how amongst people living with HIV, particularly if they were non-suppressed, having a persistence of virus. And here you see immune compromised individuals living long with their SARS-CoV-2 virus, which is mutating over time. And again, studies here showing that the likelihood of symptomatic SARS-CoV-2 was more likely in people with symptomatic illness. A bigger study was then undertaken by the WHO to show that people living with HIV had a 15% increased odds of severe presentation, 38% increased likelihood of in-hospital. Underlying conditions would also increase the risk of poorer COVID outcomes. And then, of course, the group in the Western Cape looked to see if vaccines would still work in this population. And happily, we see that there is still protection from vaccines in people living with HIV. And it really doesn't matter whether we consider infection, admission, or death, similar outcomes between people living with HIV and non-HIV infected people when it comes to vaccination. The Western Cape went on to look at other aspects, and here you see a study of seroprevalence using samples in diabetics and people living with HIV to look at the impact over time in our crowded communities. And you see in the Western Cape, although a fairly low seroprevalence at 28%, going up to 66% after wave 3, and amongst people living with HIV, 72% of people after wave 3. So an important lesson here is that the lockdown had the impact of higher seroprevalence of SARS-CoV-2 with relative immune protection in poorer communities coming at a great mortality cost. So this is perhaps an important lesson for the difference of lockdown and its value in poorer communities compared to other communities in South Africa. So you see the blue wave in Khayelitsha having a lot of cases, the second wave less so, the third wave less, and then Omicron coming back as we well know. Omicron, we really wanted to unpack what was happening. It certainly, again, in the Western Cape was able to show a lower hazard of severe outcome, but also, the effect of attenuation adjusted for prior diagnosed infection. And of course, the fact that we were having some vaccination by that time. Shabir Mahdi also published around South Africa. We now really had this increased seroprevalence And so although we began to see newer variants, particularly the BA Omicron variants, we now have a much more protected community in terms of hybrid immunity. What about vaccination? Well, extraordinary that we were able to see a vaccine within a year. And here you see the development of the vaccination, mRNA vaccines in 9 months, but also extraordinary how many vaccines were in production during the COVID-19 period. So Operation Warp Speed leading to many vaccinations. The approaches that were taken were many that had already been thought about during the search for an HIV vaccine. Here in South Africa, the focus being on Pfizer and J&J. And as Glenda's already mentioned, we have to date administered almost 13 billion shots around the world. You see where most of those have occurred. And it is projected that 20 million lives have been saved around the world in 2021. The benefits of a vaccine are both towards the vulnerable, protecting against severe disease and death, and also creating herd immunity. And we saw with our vaccines that they certainly were able to protect against hospitalization, but we saw a ding in the vaccines when it came to these new variants. So a reduction in AstraZeneca to 10%, Novavax to 43%, with some protection still from J&J to 64%, as you all well know. And this was very important for us as we were considering in South Africa at this point with the Beta variant and the worry of a third wave coming, that our healthcare workforce were very tired indeed. So we went on to make the J&J vaccine, knowing that it had some protection available to healthcare workers in the phase 3B Sisonke study. And here you see we started in 17th of February, finished vaccinations in May. We did this in multiple sites around South Africa, 500,000 healthcare workers vaccinated over that 3-month period, with an extraordinary group of vaccinators and researchers to ensure that we could bring vaccines to the healthcare workforce. We have written this up in the SAMJ, really some of the lessons we learned from that large operation. But our main purpose in Sisonke was really to keep the essential workforce on its feet. Thereafter, the vaccine program was to protect vulnerable healthcare workers from severe disease and death, prevent severe disease in the general population, and then to ensure immunity generally, aiming for as many people in the country to develop immunity. So we know that these vaccines reduce death and hospitalization, and Shirley will describe this in more detail, and did have initially a protection of infection impact. But that impact began to wane, and this is probably due to waning immunity or viral escape and low antibody levels, which then led to breakthrough infections. And this really brings us back to the impact of variants and the impact that they have on vaccines. So when we see these breakthrough infections coming through, the important thing then is to think about revaccination or boosting. And of course, as boosting happens and new variants occur, then hybrid immunity needs to be, also gain the benefit from boosting through homologous or heterologous or bivalent boosting. And we are really now in the era of vaccine boosting. And I would just say at this point that the recommendation is that if you are elderly, comorbid, you should be getting regular boosting, particularly if you have not recently had a breakthrough infection. But what was happening around the world? Well, it has been described as the 3-phase approach of rapid vaccination in the advanced economies, but very slow vaccination in the poorer communities. And COVAX was the idea to try and get vaccines to people. We know it was a good idea, but it was slow, driving discussions around TRIPS agreements again and calls for waivers. And Glenda mentioned that 24% only of low-income countries have at least received one dose, with some countries around the world having had many, many boosters to date. This has prompted the need to see if we can increase manufacturing capability, and we're delighted that South Africa is one of the first countries to see this transfer of technology, and we are a hub, and we will very soon be testing our own mRNA COVID vaccine right here in South Africa. We're also proud that our companies such as Aspen are filling and finishing, and there is a lot that we can still expect in the future. What is happening at the moment? Well, we really are seeing these variant swarms that are coming through now, the BQ1, the BA45, the XBB, and it really is kind of moving into multiple variants over time. In South Africa, we are also experiencing the BA45 and the BQ1, but happily, as I've already mentioned, we really do seem to have moved into a phase where this is not transpiring into hospitalization or cases. This is the case around the world. France is seeing the BQ11 in particular, but not really seeing an increase in hospitalization or death. And India is seeing the XBB, but again, not really cases of hospitalization or death. Glenda mentioned we lag on the vaccine side, and just 51% of our population having received one vaccine only, much fewer fully vaccinated, and this amounts to vaccine hesitancy, despite many efforts by the vaccine campaign to find ways to get vaccines to people, to listen to people on the ground and hear what was happening. We saw the listening reports, which also reported about other aspects in our community. We know that those who were vaccinated make good champions, and here are the reasons through the surveys that people became vaccinated. There are also very poignant reasons why people refused vaccination. So people were worried about side effects. They had time constraints. They were worried that they did not believe that the vaccine actually worked or that they needed them. And those individuals tended to be younger, educated and unemployed, with cognitive biases of invincibility and also distrust in the government. So this group of people who do not think they need a vaccine, are waiting to see, or who will only get vaccinated if they really have to. So that's the group we have to think about when we're really trying to get people vaccinated. And I'm drawing to a close here, but let me just conclude around a call to action for vaccine awareness and vaccine hesitancy. The first is to recognize that it is alive and well in our community. We really do need to address it at many levels, recognize that trust is key to this. We have to restore and build trust in science, invest in authentic community engagement, share best practices, encourage and support new research, and set out to build vaccine confidence. And we have to redo that. And this raises the value of community. We saw the power of community throughout the 40 years of HIV. We cannot ignore them as we go into other pandemics, not only for important messaging for public health, but also because they often can be help. And we saw in COVID-19 how community action networks came together to bring help to people who were struggling in communities. So co-chairs, I will sum up to say I believe the way forward here in South Africa and the reflections I had as a clinician scientist was that the timeline for the development of an effective COVID-19 vaccine was unprecedented. It saved many lives, but we have lost many lives whilst waiting for that vaccine. The vaccine was built on years of HIV and other viral research, and it's significant to note that it cost a great deal of money to get to those vaccines. COVAX was a good idea, but it was late and struggled to deliver on its promise. The COVID-19 vaccine saved millions of lives, but mostly in high-income countries. Equitable vaccine access is a global imperative. Vaccine hesitancy continues to undermine any vaccine campaign. And viral mutations may be driven by transmission capability rather than neutralization, which is my summing up of what I think the science is telling us. We don't yet know whether we need variant-matched vaccines. These are now coming to the fore. Bivalent vaccines are here. And so far, we've seen good and reasonable results. And so I think it's a question of how the vaccine campaign will evolve. The Omicron wave is beginning to dissolve into a swarm of sublineages. It was associated with lower mortality, which may have been due to a combination of protection due to prior infection, vaccination, and a change in pathophysiology. And boosting remains a recommendation, especially if vulnerable. Finally, the J&J vaccine saved many healthcare worker lives and may still be a good option, particularly for a more durable response. So pandemics are political and politicized. Science, however, must guide all our interventions. And this I've learned from both the COVID epidemic, but also the 40 years of the HIV epidemic, which we remember today. Basic principles prevail: understand the disease, stop transmission. Impact is direct and health resources are always key. There is also indirect consequences, which come as a result of both the pandemic and our responses to the pandemic. Behaviors, context, and settings all play a role. And that's why we need to consult with community. Community and community partnerships are key. Communication is at the heart of all of this. Innovation is critical, but of limited benefit if it's not taken to scale. Global solidarity and equity is so important, and meaningful outcomes usually need bold steps, resources, and above all, enduring compassion. And I believe that was at the heart of the Sisonke phase 3 response. And I underpin again the message today of equalize and equity. And I reflect of the value of vaccines and how vaccines save lives. I say a big thank you to our healthcare and research colleagues throughout the last 2.5, 3 years, the role you have played in our country. I want to thank the Sisonke team, people who made Sisonke and our vaccine program work. And in particular, I want to remember the co-chairs of Sisonke, Glenda in particular, and I will stop there. Thank you so much to everyone.
Thank you very, very much, Prof. One can't, I guess, not think about how the 2 years, the 2020 and 2021 were. The start of the pandemic in March, where nobody knew exactly what was happening. People were scared, and healthcare workers and practitioners were as well, as they were unsure what they were dealing with. And therefore, one cannot not but pass words of gratitude to the men and women in the healthcare space that did all they could for our people and the nation at large. The scientists who spearheaded some of the work have to be acknowledged. And so I do think this is the right time to say to all the colleagues across the breadth and length of our country, thank you for the work you did. I know that you are about to catch a flight very soon, and so you have about 5 minutes to take a few questions from the Q&A box, and I will let my co-chair Mongezi to field those questions.
Thank you, Dr. Ndlovu, and thank you very much, Dr. Gail Becker, Professor Gail Becker, for taking us through the history, from March 2020 when WHO declared this and the impact of COVID on HIV, ARVs, administrations and vaccination in children and schooling, and the impact it had on gender-based violence. So it's my pleasure now to ask our our panel facilitator, Dr. Vusmos Nhlapo, to take questions, and I encourage the participants to put their questions on the Q&A. Unfortunately, we do not have a raise hand button, so the questions will be answered from the Q&A function facility. Dr. Vusmos Nhlapo, thank you.
Thank you, Dr. Luli and Dr. Ndlovu. Prof, thank you so much for an insightful treatise, I think, in terms of, the history of the corona virus and, some of the subsequent measures that were put in place to try and respond, to the pandemic. We have 4 questions in the chat. Being cognizant of the fact that you need to be rushing, I'd like to just go through all of them. They're fairly short, and Prof can, take the 5 minutes to go through those as quickly as you can. The first question, from one of our colleagues says, are we going to see new vaccines in South Africa? Second question comes from one of our board members and wanted to know who discovered Omicron variant and in which country. The third one comes from another colleague that says, how frequently should boosters be done in the future? And I guess it will depend on how the pandemic unfolds, but how often should boosters be done in the future? And the last one, Prof, there that I'd like you to address is there is oral treatment and tablets for COVID. Why can't it be imported? Why are we prevented to send? Oh, no, that's fine. A question and comments, and no, that's fine. Maybe the main thing, that Prof, is that oral treatment and tablets for COVID are available. Why can't we import them? Prof, if you can assist us with those, please.
Yes, thanks, Vusi. So, terrific questions, and I apologize to the team that I won't be staying for the panel talk, but let me quickly go through those. Are we going to see new vaccines in South Africa? I think we're going to have to watch and see in this space. Glenda described how we write down in terms of the numbers of people being vaccinated at the moment, and that is very low. So people will also be aware that vaccines have had to be removed because they've reached their sell-by date, if you like. So I don't think that government will be importing new vaccinations unless there is a medical, clinical reason to do so, because the uptake is low. So I think there will have to be an indication that people will go out and get boosted. I have mentioned that the bivalent vaccines are available globally. And the question is whether, there will be a need to see ourselves modify our booster or move to a second generation vaccine. So I think that will determine whether new vaccines come into the country. Who discovered the Omicron variant and which country? Well, of course, our role here in South Africa has been significant through seroprevalence and monitoring the variants through genetic surveillance. And here we want to pay tribute to our lab scientists, Tulio de Lovera and others, some in private labs who've worked tirelessly. The Omicron variant was, of course, described here. And, that was important for recognition and for being able to stay on top of what was happening in the epidemic at large. And so there is a plea that we continue to monitor the types of virus that is circulating in our communities and stay on top of that. And that, of course, does mean that people need to be tested so that we can get hold of new genetic strains. And again, I think it's important that the country thinks about setting up a surveillance system going forward, pretty much like the flu system, so that we can stay ahead of new variants as they appear. How frequently should boosters be done in the future? Well, very important also to monitor that. And I think we're busy figuring that out. So we know that the mRNA vaccines wane quite rapidly, and you'll hear that in Shirley's talk. And that obviously is concerning. There is an indication that the J&J vaccine does confer more durability, and hopefully we'll be seeing more data from Sisonke to confirm that. But I think that is what is going to determine how often boosters need to be done. I think at this moment, we're thinking 4 to 6 monthly, depending on whether you have an intercurrent infection. So intercurrent infections will certainly boost immunity, but if you have not had a recent intercurrent infection, and particularly if you're over 60 or you have comorbidity, we recommend boosters. There is oral treatment. You're quite right. These are antiviral agents. They are, again, globally available. They certainly do seem to work. And again, I think the question here is we're not seeing that much severe disease in the country, although for people with comorbidity, these agents can be important for staving off severe disease and death. And I'll stop there in the interest of time.
Thank you very much, Prof. And I think that probably adds and sheds light to the questions that were asked. Being cognizant of the time, Prof, can you take one last one?
Sure.
Okay. And that is, let's see if we can get that. This is the one, Prof, as to end off with. Have you looked at the side effects of the vaccines? We are seeing a phenomenon of sudden adult death syndrome. Do you think there may be a link, as the very last question then, Prof?
Yeah, so I think Shirley will unpack that, Vusi, so I don't want to steal her thunder, but, I think we've now administered a great number of vaccines around the world, and I think if there had been a signal of sudden death related to vaccines, I think, we would have seen an indication there. And it's always important to monitor safety, particularly when a new pharmaceutical is being rolled out, and that certainly is happening around the world. So I think it's important to keep that perspective, and look forward to Shirley's talk. She'll be sharing some important in-country data along these lines. So thanks so much, and I wish you all well.
Thank you very much, Prof, for having taken the time out of your busy schedule. We don't want you to miss the flight, and just want to thank you for having contributed to the successful presentation that we're having tonight. With that, I will then hand over back to our chairpersons, Dr. Mdluli and Dr. Ndlovu, to continue with the program.
Thank you, Vusi. I will then also just give my co-chair to introduce a friend. It's always interesting to introduce Shirley, because Shirley and I have worked together before, and so I'll let Dr. Monges introduce Shirley, as well as Prof. Ames, as they will be having their talks back to back. Thank you.
Thank you, Dr. Ndlovu. So, colleagues, as we know, it's not only the many stakeholders that are involved in terms of the response to the pandemic. And now it gives me a pleasure to introduce our next speaker, who's been already introduced by my co-chair. Shirley Colley is a qualified actuary at the Discovery Health, and she qualified in 2009. She currently has the Analytic Intelligence Cluster at the Discovery, and in her role as a Chief Health Analytics Actuary, which is responsible for all clinical claims analysis, provides contract management, measurements, quality measurement, forensic analysis, and operational analysis. Her experience includes lecturing at the Department of Actuarial Sciences at University of Witwatersrand, supervising actual science students, research papers, and contributing to the syllabus of the Actuarial Society of South Africa Specialist Healthcare Technical Subject. Shirley has an extensive analytic experience in healthcare, ranging from clinical claims reporting, alternative reimbursement contracts, construction of provider profiles, and development of clinical classification systems and tools to meaningful evaluation of healthcare expenditure. Shirley has recently led a collaboration on behalf of Discovery with the South African Medical Research Council and the Sisonke team to evaluate the real world effectiveness of At26 COVID-19 vaccine. It now gives me a pleasure to introduce Shirley to give us a talk. Over to you, Shirley. Thank you very much.
Button. Good evening, everyone, and thanks very much to SAMA and the SAMRC for hosting this webinar and asking me to share with you on behalf of Discovery Health insights on COVID-19 vaccine effectiveness. And additionally, I'll share with you some of our insights on vaccine safety and post-COVID-19 recovery utilization trends amongst our client base. Also, just to state, it's really a great privilege for me to be sharing this platform with HIV treatment activists and world-class infectious disease scientists this evening on World AIDS Day, and also that we extend our sympathy to all those who have lost their loved ones to COVID-19. We've amassed a large amount of data, which has been really a valuable source of information on the epidemiology of the COVID-19 pandemic in South Africa. To date, our clients have had over 3.2 million PCR test results, of which nearly 700,000 of these were positive. And currently amongst our client base to date, we have 3,413 active cases. 9% of our positive PCR test results are likely to be reinfections, and overall 97% of our client base has recovered from their infections. The case fatality rate of our positive infections was 2.4%, and the hospital mortality rate was 15.9%. Just over 77,000 of our clients were admitted for COVID-19 treatment, which cumulatively represents an admission rate of just over 11% when reflected as a proportion of positive cases. And just over 4 million vaccine doses have been administered to our client base, and we're averaging at the moment about 21 daily new COVID-19 admissions a day. Our number of daily infections since July 2022 this year have remained low at levels consistent between earlier interwave periods. However, the quantum of testing has decreased significantly. And when we look at test positivity rates, these have been consistently high since the start of the Omicron wave. And as of today, the test positivity rate is tracking just below 20%. The number of daily admissions remain fairly low, while deaths also remain low. And in each of these graphs, you can clearly see the 5 waves of infection we've had to date, and potentially maybe a 6th wave if one just looks at the test positivity rates. Yet this isn't reflected clearly in our infection numbers, admission numbers, or death numbers. Socioeconomic factors likely have influenced access and public health messaging and deliberate campaigns and messaging across our client base have possibly contributed to the disparity in vaccination rates that we see amongst our client base versus national statistics. We see that 84% of our clients aged 60 and older have been vaccinated, whilst nationally this is at 73%. 79% of our clients aged 50 to 59 have been vaccinated versus 68% nationally, and the gap grows across the younger age groups, except interestingly for our adolescents, where there isn't actually such a large differential amongst our client base versus national statistics. And then in terms of individuals eligible for a booster dose, 30% of our clients received a dose, whereas nationally this stands at 17%. COVID-19 mortality claims have remained low in 2022 in our life insurance business, and we see from national statistics that mortality has now normalized to pre-pandemic levels. And the question is this likely to remain the status quo for South Africa? If we delve deeper into excess deaths by age group, we see a slight divergent pattern for those below 60 years old versus those above 60 years old. And that deaths for those below age 60 are pretty much settled completely at the midpoint of mortality estimates pre the COVID-19 pandemic, whereas deaths for above 60-year-olds are still hovering at the upper end of the upper prediction bound. However, the comforting consistent pattern is since our second wave, driven by the Beta variant, each subsequent wave has had lower volumes of excess deaths. most likely due to a combination of increased population seropositivity from natural infection and vaccination. What is evident from scientific experts is that there's absolutely no consensus or certainty on likely viral evolution of COVID-19, and also ultimately how it will interact with underlying population seropositivity rates. Just actually these past few weeks, there have been headlines of a study actually done several months ago of an immune-compromised HIV individual that developed various COVID-19 variants and each of these variants will have increased pathogenicity over several months, and this individual only cleared the infection once initiating ARTs. And from the same group of researchers, we saw that in vitro, those vaccinated prior to natural infection mounted stronger immune responses 23 days after natural infection relative to those unvaccinated. And that the results of this were consistent across all variants of concerns, and in particular against BA4, BA5, which are the current dominant strains circulating. Understandably, we have other public health priorities in SA, in particular HIV and TB, and that now in a post-COVID-19 pandemic world, we recognize that addressing these chronic viral conditions indirectly benefits the global response to COVID-19, given that we saw that immune-compromised populations actually have the potential to create a large population reservoir for potential future viral evolution. We've been involved in numerous studies and collaborations over the course of the pandemic, starting initially with the collaboration with the Sisonke PIs, principal investigators, on evaluating the effectiveness of the single-dose J&J vaccine for healthcare workers who were members of our client schemes. Our initial findings were shared with the public at the beginning of August 2021 by Professor Glenda Gray and subsequently published together with results and data from the government employee medical scheme in the Lancet in March of this year. We shared our first set of results on effectiveness of COVID-19 Pfizer vaccination amongst our client base in early November last year, which related to a period of time when the Delta variant was the dominant circulating variant, and consequent results on safety and adverse events in direct communication amongst our client base. And then in the middle of December last year, we released the first assessment of real-world vaccine effectiveness of the Pfizer vaccine against severe outcomes against the Omicron variant, which subsequently got published in the NEJM earlier this year. And towards the end of December, we published in medRxiv a view of effectiveness of the 2-dose J&J and 2-dose Pfizer vaccination schedule against the Omicron variant, which subsequently got published in the NEJM in the middle of this year. And in August, we shared results on the effectiveness and durability of vaccine effectiveness, and really what was unique about our data was that we had a very large exposure of individuals with a long duration since their last dose, as the rest of the world had actually begun moving to boosters several months earlier. And then our latest vaccine effectiveness study, which got published just this past September in the British Sports Journal, and in this publication, we looked at the association of physical activity and vaccine effectiveness. So just to delve into the results, the key results of each of these studies, the data showed from the start of Sisonke, which is February 17, 2021, until the study cutoff period, which was the 17th of July, 2021, amongst just over 220,000 vaccinated trial participants, a vaccine effectiveness of 67% against COVID-19 admissions, 75% against ICU, and 83% against death. This was over a period of time when both the Beta variant and then subsequently the Delta variant were the dominant variants of concern in South Africa. And the measurement was conducted by matching individuals randomly to an unvaccinated clinical twin in the insured population base matched on key demographic and clinical characteristics, and repeating this process with 500 repeated bootstraps amongst the vaccinated population in order to obtain confidence intervals around our vaccine effectiveness estimates. At the beginning of November 2021, we shared data on the effectiveness of the 2-dose COVID-19 Pfizer jab for the Discovery client base related to a period when the Delta variant was the dominant circulating variant. We found an impressive vaccine effectiveness of 79% against infection. Just to note that this VE was lower than what was observed in the original randomized control study, which was conducted at the time of circulation of the ancestral variant. And then we noted a 92% effectiveness against admission and a 94% effectiveness against death. This study was evaluated using the test negative study design, using pathology surveillance data, which is a technique which is used for assessing the annual effectiveness of influenza vaccinations. At the same time, we used the data to assess safety and adverse events associated with vaccination amongst our client base. The pace of vaccination is dictated by several factors. However, there's growing consensus that COVID-19 vaccine hesitancy was a key driver of the relatively slow pace of vaccination we saw in South Africa. And it's fueled in large part by confusion over the degree to which people might experience side effects post-vaccination, both common, mild effects and rarer, but very serious adverse events. And large-scale misinformation and fake news around vaccine side effects, particularly around the risk and rate of serious side effects, adds to the confusion people feel. Another driver of vaccine hesitancy is the belief that people are more likely to experience severe adverse events from COVID-19 vaccination than from COVID-19 illness itself. And our analysis and data showed that this certainly is not the case. In fact, contracting COVID-19 illness comes with a far higher risk of severe outcomes than COVID-19 vaccination. In particular, we saw significant increased risk of pulmonary embolism and acute kidney injury, not displayed on the slide here, but no increased risk of those particular adverse events following vaccination. And in this analysis, we replicated methodology used by Israeli researchers, Dagan and Bada, on safety and adverse events following the mass vaccination campaign in Israel. Israel was the first country in the world to roll out, to have a mass rollout of the COVID-19 vaccine, and hence a lot of the kind of world firsts of real world studies on vaccine effectiveness and safety came out of Israel. And what we saw is, well, essentially the methodology we applied was similar to the clinical twin approach we used for Sisonke 1, but here what we were looking to assess was the new onset of a specific condition for an individual compared to an unvaccinated clinical twin, also with no prior history of the condition. And we assessed the onset of this condition within 42 days post-vaccination and selected 25 conditions studied in the original NEJM study. These conditions were selected as there were possible safety signals from the original randomized control study or related to adverse events, documented adverse events from influenza vaccination. However, unlike a real-world study, the randomized control study had insufficient data to power significance of these estimates owing to how rare these conditions are. So this real-world data really enabled us to assess the quantum and the statistical significance of adverse events. Furthermore, over and above these 25 conditions, we evaluated a further 154 conditions, which may be considered to be possibly immune-mediated. So all in all, we assessed the onset of 179 conditions. And of the 179 conditions, we found increased statistical significant risk of lymphadenopathy, myositis, and paresthesia. And the risk of these adverse events from natural COVID-19 infection were in fact higher, and still the rate of complications were exceptionally low when compared to adverse events from acute COVID-19 infection. We did not note the increased myocarditis risk, which has been identified in other studies for males between ages 18 and 40, as due to our age-based rollout, we had very few under 40-year-olds vaccinated in the study period. 6 weeks after sharing the initial performance of the VE of the Pfizer COVID-19 vaccine, we were thrust onto the global stage, sharing a view of vaccine effectiveness against severe infection over the period when Omicron was now the dominant variant of concern in Southern Africa and spreading globally very rapidly. Initial data from the NICD pointed to significant increased risk of reinfection, and in vitro work showed significant immune escape from Omicron in plasma vaccinees. The question the whole world wanted to know was, did the vaccine maintain effectiveness against severe disease? And what we saw from our own data was that VE against infection was significantly reduced. But while VE against severe disease was reduced relative to the Delta variant, it still was largely maintained. By the end of December, we started getting sufficient post-exposure data for our Sisonke 2 participants to power VE estimates alongside the 2-dose Pfizer vaccine over the Omicron period. And really what we saw was that for a period of up to 2 months post-vaccination, roughly equivalent protection with both vaccine schedules. In our last study published in the NEJM, we assessed vaccine effectiveness over BA1 and BA2 proxy period and a BA4 and BA5 proxy period. And we noted significant waning in vaccine effectiveness to protection below 50%, 5 to 6 months post the last dose, which was consistent between both the 2-dose and the 3-dose regime. We saw that boosting restores vaccine effectiveness. However, this rapidly waned with time since the last dose. Also to note that the midpoint VE estimates for BA4 and BA5 tended to be slightly lower. However, these were statistically, these were not statistically significantly different. And in our most recently published piece, we noted that the single-dose J&J vaccine was more effective in reducing risk of severe COVID-19 outcomes for those who exercise regularly relative to those with low levels of physical activity. Specifically, we saw the risk reduction was 2.8 times higher for the vaccinated in the high physical activity group relative to individuals with low physical activity. In our largest study to date on post-COVID-19 utilization trends covering just over 300,000 individuals with documented infection recovered from COVID-19, we noted that an increased admission risk for up to 12 months post-recovery, but specifically during the period of infection, the admission risk was 16 times higher. The month following recovery, the admission risk was 1.8 times higher relative to matched counterparts and 1.2 times higher in the 2 to 12 months post-recovery. This excess utilization resulted in an average of 137 additional admissions per 1,000 infections during the COVID-19 episode, a weighted average of 3.1 additional admissions per 1,000 lives in each of the 2 to 12 months post-recovery. But clearly the most notable conclusion from this data is that it is rather the acute phase of the infection that has the potential to overwhelm healthcare systems as opposed to the long-term risks associated with COVID-19 recovery. We noted increased registration risk for any chronic condition, as well as for diabetes and hypertension specifically, and that this persisted for up to 12 months post-recovery. While the increased risk is statistically significant, the quantum of the elevated risk is not large at a population level. There was significant variability in risk by age and by severity of admission, and as anticipated, the greatest excess registration risk was for new chronic conditions was amongst the elderly and those who had a severe COVID-19 episode, in particular an admission into ICU. And what we did note in the study is that members who were fully vaccinated prior to their COVID-19 infection experienced no elevated risk of a chronic illness registration. So in terms of mortality outcomes, in summary, we found over the acute phase of the infection a 75 times higher on average mortality risk relative to non-infected matched clinical counterparts. But the encouraging findings were that once study participants recovered from COVID-19, there was no evidence of increased risk of mortality in the months that followed. And this was true regardless of member, sex, age, or comorbidity profile. So in summary, we saw effectiveness of vaccination during our Beta, Delta, and Omicron BA.1 wave last December. We observed significant waning of VE against current circulating variants by duration since last vaccine dose, potentially confounded by high seropositivity, giving less of an opportunity as such for vaccine effectiveness to show up. We observed low adverse event risk amongst our client base post-vaccination. And this was marginal relative to adverse events from natural infection. And we observe increased healthcare utilization post-COVID-19 recovery. However, encouragingly, this relative risk is marginal relative to the acute infection phase and is unlikely to overwhelm healthcare systems and no evidence up to 12 months post-recovery of increased mortality risk. And thanks very much for listening to me. Happy to hand over back to the chairs.
Thank you very much, Shelley. Thank you for taking us through the numbers. In terms of the PCR test done, the administration rates, as well as the daily infection positivity rates, and as well as the hospital admissions. You've touched on issues such as the socioeconomic impact, of which also Professor Linda Gale-Becker touched on. And, the real world, you took us through the real world where, one would never thought that Discover would be doing some publications. From March 19, 2022, where you had your publication in Lancet, up to September 2022 in the British Journal of Sports Medicine, where you indicated that physical activity is quite important at this stage. So you also touched on issues around the effectiveness in terms of general admissions, ICU admissions, as well as the deaths, and addressed the issues around the vaccine hesitancy and the concerns that were raised around that. And lastly, as I've said, you took us that last article around the physical activity. It now gives me pleasure to also give over to my co-chair to introduce the next speaker, who is Professor Imstai. Thank you, Chair.
Thank you, Mongezi. And thank you, Shelley, for that presentation. We will take questions after Prof's presentation. So it's my pleasure to introduce Prof. Imstai, who is the chair of the UNESCO International Bioethics Committee. She is the founder and past director of the Steve Biko Center for Bioethics at the Wits Faculty of Health Sciences. She's a professor of bioethics and health law at Wits School of Clinical Medicine and a specialist ethicist at the Office of the President and CEO of the South African Medical Research Council. Prof. Stai's CV is long as well accomplished. She's a clinician, specialist obstetrician and gynecologist, and I guess moved into bioethics and health law as the space that she sits in right now. She served 2 terms as deputy chair of the National Health Research Ethics Council and a member of the board of the HPCSA. Prof. Dai, thank you so much for your time, and over to you.
Thank you, Chair, for the introduction. I'll start sharing my screen. So can you see my screen?
Yes, we can. Thank you.
Okay, so basically what I'm going to do is look at the lessons learned from an ethico-regulatory perspective from the start of COVID right up until where we are at the moment. And I'll start off by saying good evening to our colleagues and to all that are attending this conference, this webinar this evening. So by way of outline, I'll take us through the context of pandemics as such. I'll look at some relevant ethical values, pertinent challenges, and I'll also draw from international documents when it comes to lessons learned. So when we look at epidemics and pandemics, since the 16th century, we've had about 2 pandemics per century, and that takes us to about 50-year intervals. However, when we look at our 21st century, this has changed and we're seeing pandemics more frequently. And that's probably because of our travel being opened up, trade, urbanization, and very importantly, climate change and environmental degradation. When we look at societies and how they've responded to pandemics in the past and how we responded to the COVID-19 pandemic, initially, when we heard there was something like a pandemic that had gripped us, we were quite interested. So there was immense interest. However, when we really started understanding what the true issues were, the global society was gripped with horror and panic. And as the pandemic continued, what we started experiencing was pandemic fatigue. And currently what we now see, and what we've seen with past pandemics, is this then developed into a dispassionate disinterest. And this disinterest is most frightening, because once we reach the stage, we actually pay very little attention to what were the lessons learned, because we're so busy normalizing. And we're doing that at the moment while the pandemic is still not over, such that we may be hit by the next pandemic even before we know it, and we're totally unprepared. And considering how frequently the pandemics are coming, we might even be hit by the next pandemic before we're out of the current pandemic. And who knows, this might be worse than the current pandemic. It could be much more deadly. At the beginning of the COVID-19 pandemic, every country was unprepared. Even countries that had the best healthcare systems in the world, because none had adequate public health structures to confront COVID-19. When we look at our political response, we had globally poor and inconsistent messaging, illogical decision-making, and very often COVID-19 was used to drive political agendas. We saw that globally, we saw that locally at home as well. COVID-19 also exposed corruption that we've been steeped in, globally and locally. And when our leaders made decisions for their people, sometimes these decisions were made from their ivory towers, and the decisions were so socially removed from our on-the-ground realities. We also saw a robust academic response, and we saw within less than a year a vaccine that was already developed. So we had a fantastic response from our academics and scientists, but we also saw a publication marathon, and we saw a lot of papers that were published without undergoing peer review, only to be retracted later. And so what did this do? It caused problems and concerns and impacted negatively on our social response, which was, we saw a lot of misinformation coming through, disinformation, and this infodemic also led to a pandemic. And all this then led to increasing vulnerability, where vulnerability was already present, or where vulnerability was not present, introducing new vulnerabilities amongst people. And there was a whole lot of uncertainty at the start of the pandemic, through the pandemic, and as we have actually moved through the pandemic and we are at this stage, there is still uncertainty. So taking all these into consideration, we need to see what are the lessons learned and how we address these lessons. So just to show that in the last 2 decades, we've had at least 13 major infectious disease outbreaks. And as we can see, the red, a number of newly emerging infections, and the blue, re-emerging infections and resurging infections as well. So at the beginning of the pandemic, and as we actually moved into the pandemic, when we had to face lockdowns and we had to actually stay at home if infected, we found that we were grappling with our professional ethics in terms of how do we actually respect the autonomy of our patients? In terms of our Health Professions Council guidelines, we should honor the right of our patients to self-determination, or to make their own informed choices and to live their lives by their own beliefs and values and preferences. We need to ensure that whatever we did was done with the best interests and well-being of our individual patients at heart. However, this then had to be balanced with how we approached the ethics through a public health framework, which principles included beneficence, health maximization, self-respect, solidarity, proportionality, and transparency. Now, during the pandemic and within this public health ethics framework, both explicit and implicit choices, which extended into contested and ethical terrains, came to the fore and had to be made. And central to all this was a balancing and coming to conclusions about the rights and duties of individuals, communities, populations, and governments for protecting and maintaining health, with the primary end being maximization of population health. So we saw this huge tension between individual rights founded on the principle of respect for autonomy and broader conceptions of public good. Individual responsibility also was emphasized in this public health framework. Very early on, in January 2021, the COVID-19 vaccine MAC came up with its vaccine strategy, which was guided by indigenous values of African indigenous values of interdependence, interrelatedness, and mutually respectful discussion and dialogue. And from these values, teased out 4 pivotal principles, which were specifically for the vaccine allocation, however, could be used in any aspect of the pandemic. And the first one being affirming the humanity of others, where decisions that were made had to promote the common good while respecting human dignity. Whatever was done had to be done looking at survival of communities. And here we see a very close alignment with the public health ethics framework. There was to be social solidarity, and there had to be meaningful community engagement. And that is really, really important, especially if we expect our decision makers to be trusted, and decision makers have to be trustworthy. And how would they do that? One of the ways they could do that is to have constant and timely and regular communication with our stakeholders to ensure that decision-making processes are ethical and transparent. And for this, we need integrity, which reflects the need to act with honesty. And unfortunately, we saw this really lacking in the country throughout the pandemic and even today. And therefore, what we saw creeping in also was the pandemic actually highlighting the other pandemic that we saw on the continent, the undeclared pandemic, and that was corruption. And we saw this in South Africa, how the greed had come forward by some of our policymakers and others as well. So corruption we saw as a major challenge throughout the pandemic and even now. Corruption is immoral and unethical, and there are a number of definitions for corruption, but I think for us, Waterbury actually defines it quite well when he looks at corruption as the abuse of public power and influence for private ends, where society's corruption has a link with political leadership, and we saw this happening rightly. Corruption, not only in South Africa, we saw corruption throughout the world, as we can see from Transparency International's Corruption Index 2021. And while this was happening, we also saw coming to the fore the anti-vax sentiment. It's been brought up as well already during the talk. And we also saw quite a bit of vaccine hesitancy. And initially, we saw the what was released in the research briefing between in work done by UJ and the HSRC. And in early 2021, we saw 67% of the population that they'd surveyed saying they would probably or definitely take the vaccine. But as we saw numbers dwindling, and as surveys were repeated, these numbers went down dramatically. And what was highlighted also by these surveys was that political discontent plays a role, with 36% of participants at that time saying that President Ramaphosa was doing a bad job. And based on that, they are less likely to want to take the vaccine. Hand in hand, we saw the advent of vaccine mandates coming to the fore. And while there was no mandate from a national state level, it was left to private enterprises and private entities and individuals to embark on vaccine mandates as they saw necessary. And we saw the mandates come into the workplace, come into the universities, and we also saw challenges to these mandates as well. Towards the end of last year, we saw Omicron being detected, and kudos to our researchers. And instead of our researchers being lauded globally, we actually saw that South Africans and our researchers ended up being stigmatized because of the response by the high-income countries towards South Africa and the Omicron variant, where international travel was stopped and did not want to take on South Africans. And so there were huge discussions at that stage as to what should our researchers and scientists do when they actually come up with important information that needs to be shared with the world, having learned this lesson from their honest updates to the world. How did the international organizations respond? And being with UNESCO, I'll start off with our UNESCO responses. Right at the beginning, in April 2020, UNESCO put forward its first statement on COVID-19 and highlighted the importance of the weakness of healthcare systems to be taken into consideration, and also the obstacles and inequities of access to healthcare. We also looked at allocation of resources as being important, and also a strong public health system to be of paramount importance in all state actors' agendas. We also highlighted that political choices at a macro level would inevitably have consequences on the micro allocation of resources at the point of care. For example, patient triage, and healthcare workers at this level on the ground would need to be grappling with patient care based on macro allocation decisions. We, in February 2021, put out our second statement because of the pandemic nationalism, the vaccine nationalism that we saw, and UNESCO firmly rejected this vaccine nationalism and called it a predatory rush. In other words, the political economic power to pay for large quantities of vaccines in order to distribute them to one's own citizens only. And we saw that as very unfair on a global level. And we used examples from Canada, United States, and the European Union, where they bought up much more vaccines than they actually required. We also looked at vaccines as a global common good, and we felt that for real equity in the global access to vaccines, we needed a shared ethical recognition of health as a global common good. We also highlighted that the TRIPS agreement and the instruments from the World Trade Organization were not designed to manage situations as pandemics, and these documents had to be addressed. Also highlighted the responsibility of the pharmaceutical industries to invest in facilities that were able to produce vaccines of the highest possible efficacy and facilitate rapid distribution to where they are needed. We had a third statement in June 2021, which looked at vaccine certificates per se and vaccine passports. And what we highlighted was that the introduction of COVID-19 certificates should not lead to unjust travel limitations for those who did not have access to vaccines, or for those who received a vaccine that was not accepted in countries that they wanted to travel to. And where people were actually faced with these situations, the countries that they traveled to should ensure that there were easily accessible tests made available for free to them. Going on, in September last year, we put out our fourth statement, where we drew from a Universal Declaration of Bioethics and Human Rights, where Article 15 clearly states that benefits resulting from any scientific research and its applications should be shared with society as a whole and within the international community, in particular with developing countries. At the launch of the statement, Tedros from the WHO stated, and I quote, "I need to be blunt, the world is on the brink of a catastrophic moral failure, and the price of this failure will be paid with the lives and livelihoods in the world's poorest country." And our ethics committees called for short to medium-term responses and long-term responses. And what we asked for in the short and medium term was for the expansion of existing production facilities to meet the needs of the whole world, and also for an investment in building facilities in countries that had the workforce and the know-how to produce these vaccines, and in the long term for the achievement of sustainability by empowering developing countries to make the vaccines in their own countries. As the pandemic started, I think maybe we should say waning, the effect of the pandemic started waning. various organizations started looking at what the lessons learned were. And I'll just give you a report from a preliminary draft of the International Bioethics Committee of UNESCO, where public health, ethics, and social disparities have been highlighted. And the lessons learned and recommendations would be that health policies and health systems must be conceived and implemented to include structural measures that reduce poverty, discrimination, gender inequality, political disempowerment, labor exploitation, forced migration, and environmental expropriation. And for this, we needed to have 3 guiding principles for the way forward for public health. And the first democratic guideline would be that public health decisions must ensure a participative and inclusive approach and have procedures that encourage public dialogue. There should be a second guideline, which is a fairness guideline, where public health decision-making had to favor those measures that produce the highest aggregate benefit possible, giving priority to the most vulnerable members of society. And fairness also implies that public health measures must be as cost-effective as possible. We also feel there's a need for an integrity and transparency guideline, where accountability and transparency are highlighted as crucial in the public health decision-making arena. In terms of ethical aspect, I'll just highlight the issue we had with production monopoly and inequity. And we looked at the challenge at WHO by India and South Africa, and highlighted that despite Pfizer, BioNTech, and Moderna receiving public funding of over $8 billion, they refused calls to transfer vaccine technology and know-how to capable producers in low and middle income countries via the WHO. The Lancet Commission has also come up with recommendations in terms of lesson learned, and they highlight 10 failures of international cooperation, and I won't go through all of them, but just to say that amongst the failures they highlight, they underscore the shortfall of global funding for low and middle income countries, and also underscore the failure to ensure adequate global supplies and equitable distribution of key commodities. Not only the vaccines, but protective gear, diagnostics, medicines, and medical devices. They offer 5 pillars for successful fight against emerging infectious diseases. That's prevention, containment, health service, equity, and global innovation and diffusion. And to accomplish these 5 pillars, they propose an ethical framework of pro-sociality, where they say that the orientation of individuals and government regulations must be to the needs of society as a whole, rather than to narrow individual interests. And this includes voluntary behaviors by individuals, such as the proper use of face masks and other preventative measures as well. What they propose is there should be the creation of an integrated and flexible global health fund with 3 core financing windows. One would be commodities for disease control. The second would be pandemic preparedness and response. And the third would be primary health system scale up in lower and middle income countries. The G20 report also has looked at finances, and they also propose establishing a global health threats fund, and also that at a domestic level, there has to be robust finances set aside for pandemic preparedness and prevention of infectious diseases. So in conclusion, in terms of the lessons learned, and what's really important is that we need solidarity, cooperation, and also integrity first and foremost. And we need to be responsible, but we need to have shared responsibilities. And the responsibilities and all these principles apply across the globe from global to individual. And with that, I thank you for your attention and hand over to our co-chairs.
Thank you very much, Prof, for that presentation. And just around some of very critical ethical considerations in this past 2 years, that things that we need to take on and take into the future as more pandemics come up, and I guess just as a global community in the health space. I will hand over to the SAMA CEO, Dr. Vusi Nhlapo, to take on this part of the program. Thanks, Vusi.
Thank you very much, Claude. Thank you, Mongezi, as well as our two eminent speakers, Shirley and Prof. Dai. I've got a few questions that came from colleagues, and would just request a comment from both Shirley and Prof. Shirley, the first one is, the colleague would like to find out if Discovery is tracking the impact of deferred treatments and surgical interventions, and how do these show up in your data analytics? That is the first question. Secondly, you would recall that during the high levels of lockdown, a lot of our colleagues lost a lot of income, particularly family practitioners, as patients stayed away from health facilities. Maybe at a broader industry level, how have the funders, come to the party in terms of meeting the doctors halfway? But you may be more, comfortable to talk about that specifically at the level of Discovery. Prof, two questions maybe to start off with from your side. One of the issues that has come up consistently among all our three speakers is the question of vaccine hesitancy. And a big part, I think, in terms of the work that we needed to do for encouraging people to come forth and be vaccinated. So a colleague has wanted to find out that there are a number of our colleagues, doctors and other healthcare practitioners, who are not vaccinated, and that for many other reasons. Did these colleagues who have chosen not to be vaccinated have an obligation to promote vaccination to their patients, even if they themselves do not believe in it? And I think that's important as we prepare ourselves, for other, pandemics that will be coming, certainly in the future. May not necessarily be sure how that's, soon that will be happening, but certainly I think in the future, so that you have some lessons that you learn from that. And the last one, Prof, I think came up in the previous conversation, probably just an extension on that. Why is oral treatment for COVID not available in South Africa? And Prof, might just be able to guide us on that. If the colleague says, if I get COVID, I would like to take tablets that are available, globally, but we don't have them in South Africa. They wouldn't want, to go to hospital, but rather be treated at home. So I guess maybe some of the principles around, that access to that particular form of treatment, Prof might just comment on that if you could. I'll leave it there as a starting point and see if there are any other questions that come up. Shirley, if you'd like to start.
Sure, thanks, Vusi, and thanks for the questions. So just in terms of your first question on treatment and interventions, we've certainly tracked where, since a positive case, since we're aware of a positive case, what happens to those members? Do they get admitted to hospital? And if they are admitted to hospital, what is the acuity of that admission, as well as associated outcomes, in particular mortality outcomes and length of stay outcomes? And what we definitely did see, which is consistent with a lot of other published literature, is that those individuals who were admitted into ICU had the worst outcomes. And it's one of those situations. It's not the, hopefully it's not the ICU causing the bad outcomes, but it's the underlying patient demand and severity of the patient. We have also looked at, patterns of antibiotic usage for COVID patients. And the levels did look surprisingly high. But in terms of case fatality rates, mortality rates, etc., amongst our client base, nothing that is too different to what we've seen in other countries and markets. In terms of your second question, in terms of how we have come to the party, and there's no doubt that the COVID pandemic caused a huge disruption in terms of how our members seek healthcare, and a huge impact also on the livelihood of many of the clinicians that treat our patients. And we really were dealing with an unprecedented situation. So firstly, in terms of benefits, we moved very quickly to create a benefit basket for our clients to access COVID-19 PCR testing. So that was our kind of our first and our quickest move is creating a basket for our members to access testing and also treatment on testing positive. Hospitalization care is of course covered across all our product options. And then when it came to reimbursement of clinicians and if there was some sort of relief we could provide providers, our regulator, the Council of Medical Schemes, came out very strongly towards the end of 2020 with a statement saying that the funds of the medical scheme belong to the members and they cannot be used to disperse members' funds for services not rendered. So that most definitely was a constraint in providing relief to healthcare professionals. We were definitely kind of key supporters through the Solidarity Fund and aiming to provide relief through the Solidarity Fund and PPE. And also we made sure we moved to ensure funding of PPE for all clinicians treating our members. We also some innovations, COVID really enabled us to move very quickly in funding alternative modes of care in a much quicker manner than would have been would have been the case. So we moved to fund digital consults. And also created something called the virtual house consults, which would enable GPs to reach out to their own high risk patients on our Health ID platform and initiate a consult with those members. And also another thing that we're very proud of is creating a global fee for GPs to manage patients out of hospital. I think there was a huge demand on acute facilities during some of our waves, and also to help alleviate that demand and try to keep patients out of hospital. We looked we created a global fee which covered the treatment and follow-up of COVID-19 positive members out of hospital. So I mean, those are some of the ways we came to the party, and also we very kind of proudly were involved in setting up vaccination sites to administer vaccines amongst the client base and support South Africa's mass vaccination rollout.
Thanks, Trudy. I think that's quite comprehensive and outlines the work that was done in this area to assist our colleagues. Prof, may I come to you then, please?
Okay, so thanks, Vusi. So the issue of vaccine hesitancy amongst our colleagues and the issue of, is there an obligation on them to inform their patients about vaccines? So I think we need to take our colleagues back to the oaths that we've taken, and the oaths have been to act in the best interests of our patients. And this is then further reinforced by our regulators that we are registered with, and the regulator is the Health Professions Council guideline. And if you can remember the slide, I think it's the third or fourth slide that I had on, which was the Health Professions Council guidelines, the best interests of the patients actually was highlighted in those guidelines. So if it is in the best interests of the patients to inform them about the vaccines, then there is an obligation on the healthcare professional to inform the patient. It's very important for our healthcare professionals to understand that they have to be guided by science. They may have gut feels, and they may feel in a particular way. Their personal ethics may be guiding them, but when it comes to acting in the best interests of our patients, they need to have evidence-based medicine, and they must be updated and follow science. That is why we have CPD as well at Health Professions Council, and our practitioners are bound by the CPD requirements as well. So yes, in my opinion, they would, if it's in the best interests of the patients, then healthcare practitioners, no matter what they feel and how they feel from a personal capacity, they must separate that. Look at the science and do what's in the best interests of the patient. So, and the second one is, why is oral treatment not available in South Africa? So just to understand how treatments get into South Africa. Industry makes an application to SAHPRA, which is our regulatory authority. Now, if we do not have oral treatments, it's possible that industry has not applied to SAHPRA, or they may have applied to SAHPRA, and it's undergoing the SAHPRA processes. So we do not have oral treatments at the moment because nothing has been authorized by SAHPRA. The moment they get authorized by SAHPRA, we will have them, but it will depend on the SAHPRA processes, and it also depends on whether industry makes that application. And we saw this with the vaccines. Initially we were asked, why can't we get the Pfizer vaccine? It was because Pfizer had not made the application. It came into the application process a bit late. It only came into the application process in 2021. So, and that was a few months into 2021. So a lot of it depends on whether industry makes that application to our regulator. And I hope I've answered that question. Over to you, Chair.
Thank you so much, Prof. I think that probably covers that question quite well. And I think, a detailed response to the first question as well. And I think it would resonate with a lot of our colleagues. These are some of the issues that they will face on a day-to-day basis, where you're trying to balance your own views on particular matters vis-a-vis the interest and the best, interest of the patient, as it were. Thank you so much for that, Prof. I would like us to be out of this place in 2 minutes' time. I'm just reminded by a colleague that Prof. Gailberg had indicated when we were asking about the sudden adult death syndrome, that Shirley would touch on that. So if I could just give Shirley a minute to talk about that, and then I'll hand over back to our co-chairs, Dr. Mdluli and Dr. Ndlovu. Shirley?
In terms of our data, we definitely see absolutely no evidence of increased mortality risk for individuals post-vaccination. And in fact, on our most recent analysis, we're seeing lower mortality risk. And And we think this is still, somewhat of a selection effect, because those that get vaccinated need to be healthy in the first place. And in particular, we've also looked, there was recent coverage of males having, young males also suffering, I think, from increased mortality risk linked to the myocarditis adverse event risk. We note no increased mortality risk across all age groups and across sex, across all population subgroups. We note no increased mortality risk post-vaccination.
Okay, thanks, Shirley. In the interest of time, let me thank both Prof. Dai and Ms. Colley for a great presentation. Insightful, and I hope colleagues have gained as much as I have with the presentations and the questions that were answered subsequently. Claude and Mongezi, may I hand over back to you again?
Thank you, Dr. Nhlapo, and it's my pleasure also to thank all those that have presented, including Professor Gray and Dr. Mzukwa. And I think it's for me to thank everybody who's been here on behalf of myself and the co-chair, but I'll also give the co-chair just a few minutes to say, and to introduce the last speakers in terms of saying the vote of thanks. So my co-chair, Dr. Ndlovu.
Thank you, Mongezi, and echoing your words and thanking our colleagues that have presented and those that have attended this webinar. Appreciate the time and the input. We learn every day, and what this pandemic taught us is that anything can change anytime, and so it's great that we are always upskilling ourselves in this manner. So I will be handing over to Prof. Liesel and Dr. Edward Ngwenya to close for us. Prof. Liesel comes from the South African Medical Research Council, and Dr. Ngwenya is our Deputy Chair of SAMA. Thank you.
Great, thank you very much to the chairs, and really this has been a fascinating 2 hours. I'm so pleased to see that people have stayed on even to these last moments, because it really is indicative of how incredible these speakers were, and what a fascinating topic again. I'd like to thank the 3 wonderful speakers, Professor Linda Gale Becker, Shirley Colley, and Professor Dai, our speakers that opened the session as well, and reflect that in fact the panel represented public, private and academic partnerships, really in the most almost profound way possible. And I feel that in a way is the biggest lesson from COVID, that we continue to work in that way as partners, joint endeavors. And I think our biggest challenge going forward is to make sure that we continue that momentum and don't slip back into our silos and our competitive approaches. I think we can also be very proud of ourselves as South Africans if we think of the contribution we have made during this time. So Sonke, the real world data that we heard about, the webinars, the interaction with the public, and all of the elements that Prof. Dai told us about as well. So I think what we need to know is that the future generations will probably look back on us and measure us in terms of how did we deal with COVID, and then how did we deal with recovery. And hopefully when we do that and consider again very strongly interconnectedness, equity, and addressing disparities of care, we will be measured hopefully with some positivity. So just from the point of view of the MRC, we'd really want to thank SAMA for co-chairing this webinar, for allowing us to partner with you. We're fully poised to play a crucial role in pandemic preparedness going forward. also to support and fund and empower research capacity building and science and technology development so that we can actually achieve this. And really just to thank SAMA for putting this together, and thank the audience for attending and for your insightful questions. So from the SAMRC, thank you very much. And I now hand over to my colleague, Dr. Edward Ngwenya from SAMA for the final words. Thank you, Edward, and over to you.
Thank you very much, and good evening to all of the colleagues. Always difficult to close after Prof. Liesel has spoken. But thank you all for attending, colleagues. I think we are all grateful for the pearls shared from our esteemed speakers. And we can all, I believe, certainly agree that we have gained much insight from different perspectives, actually, the clinical, the research, the statistical, even the ethical perspective. However, it is evident that there is no crystal ball that we can gaze at to focus what the future may look like. However, I would like to reiterate the words that investment in research with the South African Medical Research Council and other bodies is the only guiding light to us as scientists. This should be done under the guidance of ethics and not merely economics, politics, and competition, as well put by Liesel. Our collaboration as SAMA with the SAMRC on this webinar, I can certainly say, has definitely succeeded in arming our colleagues with information on how to navigate the road ahead. Allow me to just succinctly take this opportunity to thank the South African Medical Research Council, who, by the way, have been always eager and available from when we started, with COVID, all the webinars that we've had, always there to give information. Thank you to Prof. Glenda Gray, the chair, to Prof. Liesel Zucker, the vice chairperson, and the colleagues in the South African Medical Research Council. And of course, a great thanks to our esteemed speakers, Prof. Becker, Miss Shirley Coley, who we've now given an honorary doctorate today as Dr. Coley, and Prof. Ames Dye, who also serves as a member of the South African Medical Association Board of Directors, and a forever a light and an inspiration in all areas. Co-chairs, thank you to Mongesi Mdluli and Dr. Claude Ndlovu, our South African Medical Association Chairperson, Dr. Mvuyisi Mzukwa, CEO, Dr. Vusumuzi Nklapo, and let's not forget there are those who are behind the scenes. In fact, those who had registered, I think we got right to 900 participants. There are people who are working behind the scenes, and behind there on the IT side and assisting us with the technological elements, Renier Lataghan. Thank you, and thanks to Nomonde Suzman and Diane Smith, who's also been exceptional in all the processes leading up to this. And last but not least, thank you, the attendees, for taking the time to come here and empower yourselves in all of this. Allow me to end with the words of Winston Churchill, who stated, "Now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning." With those few words, I would like to thank you all and take this moment to declare this webinar closed. Have a lovely night and take good care in the festive seasons. Thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Cheers.
Thank you. Bye-bye.
Bye, colleagues.